Hi everyone, I'm Dr. Windsor. Welcome to my lecture on Chapter 2. This is going to cover the first half of Chapter 2. And in this chapter, we're going to be focusing on legal concepts, risk management, and ethical issues. While these concepts may not be the most riveting to learn about, they are important to us as CSTs because a better understanding of these legal concepts will help us to be better caregivers. Patients place their lives in our hands, and so we have an obligation to not only be an advocate for our patients, but to remain accountable for our actions. Both honesty and sound judgment are crucial to quality patient care. So after studying this chapter, we'll come away with a better understanding of the legal aspects of healthcare, as well as the ethical and moral behaviors necessary to provide proper patient care. We're also going to dive into risk management and scope of practice. The American Hospital Association, or AHA Patient Care Partnership, which we will discuss in greater detail later in this lecture, defines the patient as an autonomous individual who is in need of a service that he or she cannot provide for himself or herself. This means that the patient, under the Patient Self-Determination Act of 1990, retains the right to direct his or her own patient care. And this also includes the right to refuse treatment, which we're going to talk about more in a little bit here. So we're going to go over some key terms. Please make sure that you review these terms and are familiar with their definitions because you'll probably see them on a quiz or a test in the near future. So we're going to start at the top left-hand column with accountability and kind of work our way down. So in the left column, you're going to see the terms, and in the right column, you're going to see the definition. So we're going to start with accountability. I'm going to give you a couple seconds to look over these kind of condensed definitions and see if you can find the definition of accountability. All right, let's see if you found the right one. The definition of accountability is obligation or a responsibility. Now, what about an affidavit? What's an affidavit? Well, an affidavit is true facts that are sworn before an attorney. Now, an allegation is a statement expected to be proven as true. Now, what about bona fide? What does bona fide mean? Out of the ones that we have left, bona fide means good faith or innocently. Now, case law. Case law is a legal decision on a legal subject. Now, what about complaint? We have a couple left, so we're narrowing them down. A complaint is the first pleading that is filed in a case. And then lastly, defendant, we should be able to find that one, is the person or organization accused of a crime. Moving on with some more terminology, but we're going to flip it on its head now. On the left-hand side, we're looking at the definition, and on the right-hand side, we're looking at the word. So let's find the word that means taking another's property without consent. Taking another's property without consent is larceny. What word means court-appointed protector? Well, that would be a guardian. What about a formal written accusation? Formal written accusation. The term for that is indictment. What about pre-trial discovery under oath? What would be the term meaning pre-trial discovery under oath? That is a deposition. What about court that interprets Constitution, acts, and treaties. That would be federal law of court. Now, what about citizens that decide the outcome of a trial? That's a pretty easy one. That is jury. And then lastly, result of activity of a healthcare provider would be an iatrogenic injury. All right, moving on. What about the omission or commission of an act? What word on the right means omission or commission of an act? That would be negligence. So if you guessed negligence, great job. What about evolving principles based on court decisions? Which term does that match up with? If you said law, common, you would be correct. What about obligation of a corporate body? That term is liability corporate. So obligation of a corporate body is corporate liability. What about professional misconduct that results in harm? Professional misconduct that results in harm. That would be malpractice. The obligation of an individual. Which term means obligation of the individual? That is personal liability. So remember, obligation of a corporate body is corporate liability. Obligation of an individual is personal liability. Couple more here. What about reckless disregard for the safety of another? What do you think that is? Reckless disregard for the safety of another. You have two choices. That is criminal negligence. And then lastly, law prescribed by the action of a legislature is law statutory. Remember, common law is evolving principles based on court decisions. All right, we have a few more terms here. Again, the definition being on the left and the term being on the right of the screen. First definition, false testimony under oath. What do you think that is? If you said perjury, you would be correct. Perjury is false testimony under oath. What is the term for a civil wrong? A civil wrong. That is a tort. If you said tort, great job. What about expected conduct of a professional? The expected conduct of a professional. That is the standard of care. The standard of care is the expected conduct of a professional. What term refers to a legal principle? What do you think? If you said precedent, great job. Next one, state statutes, regulations, principles, and rules. If you picked state law, great job. Couple more. Person who initiates a lawsuit, who is that? Couple to choose from. Plaintiff is the person who initiates a lawsuit. And then lastly, a subpoena is a court order to appear or testify. Continuing with some terms regarding legal doctrines and traditional principles. The first one here, presentation of evidence in a court of law. I guess that's finishing up legal terms. Which one do you think that is? That is a trial. A trial is the presentation of evidence in a court of law. Pretty common term there for us. All right, which phrase on the right means the patient first? The patient first. If you picked agere primo, you would be right. Great job. What about the ability to predict an outcome? The ability to predict an outcome. That is a doctrine. It's the doctrine of foreseeability. We can predict what the outcome is going to be. Which phrase on the right means the healthcare facility can be found negligent for failure to ensure quality patient care? The healthcare facility. That would be the doctrine of corporate negligence. Now, which one means above all, do no harm? Above all, do no harm. Which one do you think? If you picked primum non nocere, you are correct. Very good, that's Latin. A couple more here. Person controlling or directing employee has a greater responsibility. Which doctrine is that? That is called the doctrine of the borrowed servant. So the person controlling or directing the employee, let's say the surgeon. The surgeon controls and directs us as the SurgTech. According to the doctrine of the borrowed servant, that surgeon has a greater responsibility than even the hospital itself. And then lastly, each person is responsible for his or her own conduct. That is the doctrine of personal liability. One last slide, just going over some legal doctrines and traditional principles. Which phrase on the right do you think translates into the thing speaks for itself? The thing speaks for itself. That would be res ipsa loquitur. Next one says, person should perform an action as would any reasonable person. What do you think? Doctrine or some Latin mumbo jumbo? That is the doctrine of the reasonably prudent person. And then lastly, let the master answer is respondeat superior. So a lot of terminology in this chapter. I'm going to be posting these PowerPoints so that you can quiz yourself. You could use this as a quiz tool if you would like. Okay, so now we're going to get into a little bit more of the meat of the chapter. We're going to talk about torts. Now, there are two types of torts, intentional and unintentional. Remember, a tort is any civil wrongdoing independent of a contract and provides a remedy in the form of an action for damages. Most actions against operating room personnel are civil actions rather than criminal, and as I mentioned, can be unintentional or intentional. However, unintentional torts are the most common types of patient care errors, which means we didn't do it on purpose. So let's talk about intentional torts first, and then we'll discuss unintentional torts. Now, intentional torts are purposeful. Like I said, we did it on purpose, and it violates the patient's rights. Some examples of intentional torts include the following: assault. Now, a lot of times you hear assault and battery used together. Sometimes they get confused for one another. Assault is the threat that evokes fear. It can be offensive, insulting, or a threat to harm. It's the word part. Battery is the physical harm of a person, to include contact without consent. So like I said, sometimes these two can get confused. So maybe this saying might help you. A before B, assault before battery, or threat before harm. Now, defamation is another intentional tort, and there's two different types: oral defamation and written defamation. So an oral statement is referred to as slander, and the written defamation or statement is referred to as libel. And these defamations can damage a person's reputation or their name. So an example of slander, remember that's an oral statement. Did you hear that this patient did such and such? Or libel, remember that's written, could be some sort of social media post about what a patient did. False imprisonment is also another type of intentional tort, which means holding somebody illegally against their will. So for example, if we put a patient in seclusion or we tie them down to the bed without a medical order, this would be considered false imprisonment. Another example of an intentional tort would be intentional infliction or emotional distress. So these are hurtful remarks made about a patient that results in emotional stress. There's also invasion of privacy. Invasion of privacy is the disclosure of somebody's private information about themselves or a photograph of them without consent. I have an experience related to that. I was working at a surgery center, and one of the nurses was in a podiatry case, which is a foot case, and they were fixing this patient's bunion. Well, I guess the foot was really deformed, and this particular nurse took a picture of the patient's foot and posted it on Facebook saying, "Look at this really gnarly, disgusting foot I fixed today." Well, somebody that was connected with her showed somebody else that worked at the hospital, and the next day, that person went and showed it to our operating room director. And consequently, the nurse was dismissed from her position, even though it didn't have any specific patient information like their name or their age or the hospital or whatever. The nurse was dismissed immediately because she photographed the patient and there was not a consent for that. So it's really easy today for us to snap some pictures, and it might be really fun and you want to share them with your friends. You're really excited about what you're doing in the operating room, but we really want to be careful about doing that because it could have dire consequences. All right, like I mentioned previously, unintentional torts are the most common types of patient care errors, and there are two types of unintentional torts: negligence and malpractice, with negligence being the most common type of unintentional tort. So for an act to be considered negligent, certain criteria must be established. First, there must be proof that the defendant had a duty to the plaintiff. Secondly, there must be proof that the defendant breached that duty, and they must also prove that the defendant's conduct was the cause of the harm to the plaintiff. And lastly, the plaintiff must have sustained an injury. So for it to be considered negligent, all of those boxes have to be checked. Now let's look at some examples of negligence that can occur in the operating room. Some of those include patient misidentification, performing an incorrect procedure. You might also hear this called wrong site surgery. This is where the timeout was born. We didn't always do a timeout, but there was an increase in wrong site surgery or incorrect procedure. So the timeout was invented to make sure that we stop before we perform any procedure on a patient, and we all agree that this is the right patient and the right procedure, and so on and so forth. Another example of negligence that can occur in the operating room is a foreign body that's left in a patient. Now, we don't want to send the patient home with anything that they're not supposed to have inside of their body, like a sponge or an instrument or a piece of a broken device or scalpel or suture needle, anything. According to the American College of Surgeons, 1 in every 5,500 procedures involves a retained item. All right? I always say we don't close a wound if the count is incorrect. So if something gets left inside, there was a counting error somewhere or something was overlooked. These foreign bodies that are left in patients cost an average of $150,000 per patient. So like I said, this could be a sponge. I was called in to help with a procedure where a patient had a breast biopsy and the wound wasn't healing. So they came to our facility and had an x-ray, and they found that there was a sponge that had been left in the breast, and we had to go in and remove that. So the patient had to have a subsequent surgery for that. Also, one of my past campus directors, her father had his appendix out and they left a sponge in, and it really didn't reveal itself until years later when it had caused some problems inside where it was actually strangling his intestines and he wasn't able to have a bowel movement. So these things may have immediate consequences or they may have consequences down the road, but we need to exhaust all efforts to make sure that we are not leaving foreign bodies inside our patients. Another example of negligence is a patient burn. All right, this can happen from instruments that have come out of the autoclave. When metal instruments get sterilized in the autoclave, when they come out, they're about 275 degrees. We want to make sure that we cool those down before they touch our patient. It could also be the result of an improper grounding pad placement. When we use cautery in surgery, a lot of times, well, depending on what type of cautery it is, if we're using the monopolar cautery, the patient has to have something called a grounding pad, and this closes the circuit for the electricity. When the electricity goes into the body, it has to have a place to exit, and the sticky pad that we put on the patient's leg provides that. And if we don't get that attached to the skin well, that can also cause a burn. Malfunctioning equipment can also cause burns, improper use of lasers, and sometimes we use solution to clean the patient's skin that has a high percentage of alcohol. And if that is not allowed to dry properly, or for some reason a puddle gets underneath the patient, that can catch on fire and that can cause a burn as well. Something that we want to make sure that we do is that we always keep our bovie in the little holder that it's supposed to go in, so that it doesn't accidentally get the surgeon doesn't accidentally activate it, that's the word I was trying to think of, and it consequently causes a burn. There's also light cords that we use when we're doing scopes, and those are also very hot as well, so we want to make sure that we keep those away from the drapes and away from the patient, away from their skin. Falls or positioning errors are also examples of negligence that can occur in the operating room. And I had an experience where a patient actually fell off from the operating room table during a surgery. We were removing the patient's gallbladder. It was on a Saturday. There was very few people there, just what I would call a skeleton crew. And when you take a gallbladder out through the scope, you position them with their feet down and their head up, and rotate them a little bit to the left. So this causes the abdominal contents to fall kind of down and away from where the gallbladder is. Well, the patient, as the surgeon was wanting the patient table, the OR table turned a little bit more to the left, a little bit more to the left, the patient started coming off the table. Thankfully, we were able to control the descent to the ground. However, that was, a sentinel event. But thank goodness there wasn't any injury that the patient sustained from that. Another example is improper handling, identification, or loss of a specimen. Now, I did a little bit of research, and what I found is that this occurs at a rate of about 0.1% to 5% of the time. And according to one of the plastic surgeons that I used to work with, 10% of breast cancer diagnoses come from testing tissue from breast reductions. And I mention this because when we do breast reductions, we have 2 specimen containers, one for the tissue for the left breast and one for the tissue for the right breast. And it's our responsibility as the surgeon is removing tissue to make sure that it gets in the right bucket. Well, what if the scenario was some tissue from the left breast that ended up being cancerous was put into the container with the right breast tissue? We would now then think that the patient has cancer in the right breast when it is really cancer in the left breast. So we want to be very diligent when we are handling specimens, identifying specimens, so that we make sure that we label them properly, that we don't get them mixed up, and of course that we don't lose them. Another example that I have here is incorrect drugs or incorrect administration. Now, 7 million individuals are affected each year from incorrect drug or incorrect administration of drugs. That costs the industry about $40 billion each year. Now, I had a student that was out on his clinical rotation, and his preceptor had stepped out of the room, and the nurse was giving him medications. It was for a vascular procedure, and he mislabeled 2 medications that would have been extremely dangerous if they were to be mixed up and administered one for the other. And the site called me and asked for the student to be withdrawn from the clinical site. So again, be very, very diligent when you are handling medications and labeling medications. And you'll learn the process of how to do that as you get further along in your program. Another example is harm secondary to the use of defective equipment or instruments. It's our responsibility to check all devices and all instrumentation prior to use and when they come back to us after the surgeon has used them, to make sure that all of the parts and pieces are there and that we didn't leave anything inside of the patient, or that they are still in working order. Another example, loss of or damage of patient's property. Harm secondary to a major break in sterile technique. This can result in limb amputation, multiple debridements and bringbacks to the operating room, or perhaps even the loss of the use of a joint. Another example still is exceeding authority or accepted functions, violation of hospital policy or the scope of practice. Abandonment of the patient is the last example that I have. We never want to leave a patient in the operating room by themselves, and we never want to leave the patient unattended on the OR table. All right, that was a lot of talk about unintentional and intentional torts, and we're going to kind of shift gears and talk about the consent for surgery. So surgery is not performed without written and informed consent of the patient. And there are a few exceptions. However, in most instances, performing surgery without the patient's consent would be considered battery. So whomever is consenting must have the capability and the authority to do that. Also, it requires at least 2 individuals to consent, the recipient and the person performing the action. So in this case, the patient would be the recipient and the surgeon would be the person performing the action or surgery. Now, consent can be expressed or implied. Expressed is a direct verbal or written statement granting permission for treatment. Implied consent occurs when the healthcare provider believes that the patient had given consent, although no direct or verbally expressed consent was given. Now, in healthcare, a written expressed consent is the desired form of consent. More specifically, we use something called an informed consent, and we're going to talk more about that next. The informed consent protects both the patient and the provider, and the Joint Commission defines the informed consent as this: an agreement or permission accompanied by full notice about what is being consented to. It goes further to say that it is the requirement that a patient be apprised of the nature and risks of a medical procedure before the physician or other healthcare professional can validly claim exemption from liability for battery or from responsibility for medical complications and other undesirable outcomes. The surgeon is typically responsible for securing written informed consent. Now, the surgeon will discuss all of the risks and answer all of the questions that the patient may have prior to the patient signing the consent form. There are 2 categories of consent that we use in the hospital setting, and those are general and special. Now, a general consent is one that the patient signs when they enter the hospital. When they sign a general consent, the patient is agreeing to routine services like diagnostic procedures, routine touching, testing, etc. Now, the general consent cannot be used in place of a special consent. A special consent is obtained for any procedure that entails abnormal risks. For example, if the patient is having surgery, or any fertility or sterilization procedures, if they're going to be undergoing anesthesia or any types of transfusion or chemotherapy. And of course, that's not an exhaustive list. So this includes any procedure where a device will be implanted into the patient, like a pacemaker or a artificial heart valve or a stent, or maybe they have a broken arm or leg and they're going to require plates and screws to fix it. Next, we're going to talk about the required conditions that must be met when securing the informed consent. So it's important to note that the information provided during the consent process may vary due to several factors, like the patient's age, their condition or psychological status, their language, and their cultural background. The healthcare provider must also take into consideration the fact that it is highly unlikely that the patient understands medical language and the jargon that we use. And sometimes we forget this because words like cholecystitis are everyday words for us. Conversely, we want to use simple language that the patient can understand. And this is one reason that My mom always asks me to go with her to her doctor's appointments because she says that she doesn't understand all the big words that they use. And sometimes those really big words, even if they're benign, can be really frightening to the patient. Lastly, we need to remember that the patient has a voice in their treatment. We want to ensure that they don't feel coerced or pressured into a specific treatment. So providing any alternate pathways of treatment is going to be imperative. Next, we're going to learn more about the specific provisions for informed consent. So provisions are dictated by medical practice acts and state laws, which do vary from state to state. However, an informed consent at a minimum should contain the following things: the patient's legal name and surgeon's name, the procedure that's going to be performed, and if it's side specific, like right arm, left arm, that needs to be identified as well. The risks of anesthesia and procedure, including complications, need to be listed, as well as the patient's legal signature and the signature of the witness or witnesses, and the date and times of the signature. There are also special conditions that the patient must meet, which we're going to learn about what those are coming up on the next slide. The patient must meet the following conditions for informed consent. So they have to be of legal age or legally emancipated minor. They have to be mentally alert, legally competent, and not under the influence of alcohol or drugs. Also, the patient needs to be, like I said, of legal age. And there we go. It's really important to note that the informed consent must be signed prior to entry into surgery or the treatment area, or the procedure must not be performed. We have to have a consent. However, there are a couple exceptions to this. Special circumstances might include illiteracy, where they might have the patient just put an X for their name, sensory impairment, language barriers, and emergency situations. So if the patient is physically unable to provide consent, another authorized person may need to provide it. So those people could be the courts, temporary guardians, hospital administrators, parents or legal guardians of minors, a competent adult that can speak for themselves, of course, or guardians of those that are physically enabled or legally incompetent. So make sure that you look at your textbook for an example of the basic informed consent. While state laws and facility policies do vary, some acceptable methods of securing consent under emergency circumstances are the telephone, electronic, administrative, or the agreement of two consenting physicians, which excludes the OR physician. Implied consent is never the preferred option. We only want to use this in emergency situations. So sometimes during surgery, the procedure might extend beyond what is in the informed consent. For example, the patient is consented to have their gallbladder out. Let's say when we get in there, the surgeon sees some strange lesions on the liver and they want to do a biopsy. This would extend beyond the informed consent for gallbladder removal. However, the biopsy would be warranted in this case. Remember, if a procedure extends beyond the consent, it must be able to be proven that good judgment was used or the surgeon could be liable. They can't just be in there to take out the gallbladder and then just get a wild hair to take out the appendix just for the fun of it, all right? So these occurrences are covered by something called the extension doctrine. Now, the extension doctrine implies that the patient has given consent for correction or treatment of conditions that were not expected or anticipated by the surgeon. In my experience, consent typically identifies the specific procedure, but includes additional verbiage like any additional necessary procedures. Remember that the patients have the right to refuse treatment or change their mind at any time. And if a patient does withdraw consent, it should definitely be documented and noted in the patient's chart. Now let's talk a bit about documentation. Have you ever heard of the saying, if it wasn't documented, it didn't happen? Nowhere is this more true than in the field of healthcare. Generally speaking, documentation refers to the information that's placed into the patient's chart or medical record. So what are some of those components? Well, the book lists a few for us, and some of those include the patient's diagnosis, the medication record, discharge instructions, identification of the patient, follow-up treatment, medical history and physical, any test results that they might have, along with the identification of the healthcare providers involved in the patient's care. Even our name is going to go on the OR record if we help with the patient's surgery. We're also going to put the intraoperative record will also become a part of the medical record. So this is the record that is completed by the circulating nurse intraoperatively that tells about everything that occurred in surgery. So what procedure was performed, what type of anesthetic the patient was given, when were the counts performed and were they correct and what was counted, if the patient has any drains or catheters, what their dressings are, the medications that were given intraoperatively and the amount of the medications that was given intraoperatively, along with any complications that may have occurred. They're also going to note the estimated blood loss, the position of the patient, and what the patient was prepped with, along with the identification of the surgical personnel. And this is to include any personnel that provide breaks or relief during the case and any specimens that were collected. Just a little side note here that the anesthesia care provider will also keep his or her own record that will be added to the medical record as well. Additional things that are considered documentation that you might find in the chart is any births or deaths, as well as any charges that are incurred during patient care and their insurance providers if they have insurance. Proper documentation is extremely important because it not only protects the hospital, but it protects the hospital's employees and the patient. Now, errors do occur because we're humans and we make mistakes. If we find that an error has occurred, the way that we should take care of that is to mark through the error with one line and write the correct information directly above it. Now, as surgical techs, we don't do a lot of charting. When I was working in the kind of traditional role as the surgical tech, I didn't put anything into the chart. I didn't look at the chart, I didn't chart in the chart, I didn't add documentation of the chart, nothing like that. But when I worked in labor and delivery, I built charts, I did vital signs, I charted a lot of stuff, everything about the baby, how much they weighed, when it was born, how long it was, all of those things, when I gave its first bath, what its vitals were, if we had to, monitor its blood glucose levels, I would document those things as well. So it's, how much we're in the chart and charting is really dependent upon the role that we're filling as the surgical technologist. You want to make sure that you look in the text and you familiarize yourself with the Joint Commission's do not use abbreviation list. Probably see that again in the future when you're in pharmacology, but definitely something to take a look at. All right, so that is going to bring us to the end of this slideshow for part 1 of chapter 2. Thank you very much for listening, and let me know if you have any questions.